the other important thing, once we look at the intra-auditory meatus, see, if I look at the intra-auditory meatus here, there are so many things which are emerging from the intra-auditory meatus. The first thing, see here as well, this is intra-auditory meatus. If I come from top to bottom, the first thing coming anteriorly from the superior part is the facial nerve. See, this is the facial canal. That is the labyrinthine segment of the facial nerve. If it is clear to you, hope it is clear to you.
Yes, it's clear.
That's the labyrinthine segment, and you can see dynamically that is the first genu. That is the horizontal segment. As I go down, that's the horizontal segment of the facial nerve here. And if I go down, you can follow with the second genu and then the vertical segment. This is best seen on a dynamic CT scan where you can relate three-dimensionally everything. Kapil, you asked me in the beginning, if patient is carrying a CT scan in hand, would you repeat? If the patient is carrying a printout, I will definitely ask for a repeat CT in digital format. But yes, if the patient is carrying already in a digital format, there is no point in repeating a CT scan, and the anatomy is not going to change. But we need a complete in-depth three-dimensional information of the anatomy, which can only be gained optimally by a digital information, a digital, data of the CT scan. Do you agree with me?
Yes, sir. Totally agree.
So this kind of, this dynamic information is required where every structure you can relate dynamically to each other. So this is the level of the CT scan. In as I said, in abnormalities of the semicircular canal commonly, and sometimes in the inner ear abnormalities like common cavity, in a cochlear hypoplasia, and sometimes in other abnormality, this facial nerve location may be abnormal, and one should be prepared to look at it by a preoperative CT scan and accordingly deal with it intraoperatively to prevent a damage to the facial nerve. So this is important to look at the CT scan, the anatomy of the facial nerve, the entire course, right from the labyrinthine segment to the labyrinthine segment here to the this is horizontal segment here, that is on the right side, that is second genu, and this is the facial nerve here at the vertical segment. Now there are a lot of discussion about looking at the facial nerve in view, as the commonest technique of the cochlear implantation is posterior tympanotomy, and people have described n number of ways to see the visibility of round window through the posterior tympanotomy, whether it is a favorable round window or not, because the anatomy of the round window, orientation of the cochlea is different in different individuals. There are a lot of publication describing the orientation of the cochlea. Let me tell you what exactly we mean by the orientation. See, this is the sagittal plane, and if I make a line traversing the basal turn of the cochlea, the length of the basal turn of the cochlea here, see, exactly that is the angle we want to know. That a lot of people have described this angle. More the cochlea is obtuse, more the angle is narrow, both the ends give you difficulty in visualization of the round window. Difficulty. With experience, you can overcome easily all these difficulty, but this is important to, as far as the teaching is concerned, these are important discussions so that you can be more prepared in dealing with difficult or unfavorable round window. Unfavorable means, by and large, to be very precise, we want to see the round window through the posterior tympanotomy, through which we can, by round window or extended round window or whatever approach, we access the scala tympani of the cochlea, basal turn of the cochlea. Now, if the round window is unfavorable, it is not visible to the posterior tympanotomy, is a difficult task then how to approach the cochlea. One can get disoriented, or one may implant the the cochlear implant outside the cochlea somewhere, or misplace the implant into different locations. So in order to know the surgical difficulty, whether the round window will be favorable or not during surgery, the simplest way, there are hundreds of ways you can see, and see one of the ways you can easily see. Let me show you, take you back to the facial nerve. See, this is the facial nerve again, the horizontal segment of the facial nerve. And if I am going here following, see my cursor is following the facial nerve here in the vertical segment. That's the vertical segment of the facial nerve. Can you see this? Can somebody remove this? Boss, Dinesh ji?
Yes.
Yes. Yeah. See, this is the vertical segment of the facial nerve where my cursor is. I hope it is very clear.
Yeah.
So this dynamic CTs can take you directly to the structure which you want without disorienting you. That is another beauty of having the CT scan in a dynamic way. Now, this is the basal turn of the cochlea. In the long axis of the basal turn, you are supposed to implant. Now, how you are coming in the posterior tympanotomy? Suppose, let me tell you the angulations of the this is the long axis of the basal turn of the cochlea where we need to implant. Okay. This is the facial nerve. In posterior tympanotomy, facial nerve is a medial anatomy. Posterior tympanotomy is a triangular space between the lateral canal, the extra-auditory canal laterally, and which is demarcated at the medial end by the chorda tympani, and the facial nerve medially, that triangular space. Now, if I draw a parallel line through the anterior wall of the facial nerve, see this? My facial nerve, this line is the medial limit of my visualization, which I am looking from laterally here. And the second line, the anterior line of the visualization is the extra-auditory canal. Look at the extra-auditory canal here. If I draw another line parallel to the extra-auditory canal, in the way I am going to see from behind. See this parallel line? See those two lines. Imagine surgically where you are doing a posterior tympanotomy, wherein my lateral limit or the anterior limit here is going to the chorda tympani demarcated by the medial end of the extra-auditory canal. This is the medial end of the extra-auditory canal here. And my medial line, my medial limit is going to be the facial nerve, which is the second line here. Through this visualization, through this, I need to seek into the long axis of the cochlea. If the long axis of the cochlea falls between these two lines, by and large, your round window is going to be visible through the posterior tympanotomy. Got my point or not? Agreed or not? There are hundreds of ways to, there are so many angulations, so many, formulas have been described by various people, making it more and more difficult for everybody to understand the accessibility of the round window, visualization of the round window or the favorable round window through the posterior tympanotomy. This is what we need to know practically between the line of the extra-auditory canal and the facial nerve, the lateral part of the facial nerve. If through this axis laterally, I am going to see here from laterally between these two lines, if my long axis of the basal turn happens to fall between these two lines, my round window is going to be accessible. Kapil, any comment, or you look at it differently?
No, sir. We more or less use the same method of assessment. Basically, it's the cellularity and the thickness of mastoid bone between posterior canal wall and the vertical facial nerve. And
Yes.
you are very right. If your round window is seen within that triangle, then the access will be easy.
Absolutely. So this is one of the practical ways, I would say, to look at the round window. Now see, I can show you, if you see very carefully, let me enlarge where the chorda tympani is. See, to tell you everybody how to look at the chorda tympani. See this, follow the facial nerve. This is horizontal facial nerve. I am going down. This is vertical facial nerve, vertical facial nerve. Vertical facial nerve, vertical facial nerve. Can you see some nerve is joining here? Chorda tympani emerges from the lower part of the facial nerve just before the stylomastoid foramen. And see this nerve which is emerging. Can you see this? This small nerve where my cursor is going. I'm following it up, following it up, following it up. Can you see this small nerve? Yes or not? Can you see this small nerve where my cursor is? Very small nerve. That is the
Yes, we
chorda
can see.
tympani. That is the chorda tympani, and where it is going? To the medial end of the extra-auditory canal. See, this is your chorda tympani, this is your facial nerve, and in between is your long axis of the scala tympani or the basal turn of the cochlea. So that can tell you exactly. See, In the CT scan, I'm looking from laterally between my both limits, the facial nerve and the chorda tympani here, to the long axis of the basal turn of the cochlea. This is what we need to see intraoperatively in cochlear implantation. That is what my submission, to look at how to look at this, important aspect to see the feasibility of round window visualization. Now, coming after this, the another important thing, once you look at the cochlea, see this, the cochlear anatomy, we must know in all the three terms whether the cochlea is normal in terms of, morphological development. See the apical, middle, and the basal turn all together. Can you see? And this is the section, I would say, the mid-modular section. You can see wherein all three terms of the cochlea are visible, and this is the modulus, and this is the cochlear aperture. See this. This is the intra-auditory meatus again. This is the intra-auditory meatus, and from here, the cochlea is, related to the lateral end of the, intra-auditory meatus. This little bright and ossified, this is porous bone that forms the modulus, and that is sitting at the cochlear aperture, closing this cochlear aperture. In situations where the cochlear aperture, the modulus is deficient, what you can imagine, what is going to happen simply is going to be a gusher. So gusher is totally attributed to the abnormal communication of the lateral end of the intra-auditory meatus to the cochlea. When the cochlear aperture is deficient, the cochlear aperture is widened. When the modulus is deficient, when there is through and through communication of the base of the cochlea with the intra-auditory meatus, the gusher is likely. No single case of gusher has been attributed so far to the abnormal cochlear aqueduct. That's a misbelief. It has been, studied as one of the potential source of, gusher in the cochlear implant surgery or stapes surgery, but the role of cochlear aqueduct is different altogether. We'll discuss in stapes surgery in detail, but we'll need to know where the cochlear aqueduct is and how important it is as far as the, gusher is important. So cochlear aqueduct has practically no role in contributing to the gusher. It is almost always the lateral end of the intra-auditory meatus, which is in abnormal communication with the cochlea because of deficiency at the base of the cochlea at the level of the modulus. When this deficiency is there, the cerebrospinal fluid is in direct contact with the cochlea and it flows freely. Once you open the cochlea at the round window of cochleus mean, you're likely to get the gusher. And this you can preempt quite effectively by means of a CT scan if any of these abnormalities you may find. Sometimes we have seen in a couple of cases wherein there was direct abnormal communication of the cochlea with the intra-auditory meatus with modulus deficient, and yet there was no gusher because we can't pick up the membranous, limitation, the membrane which is separating the cochlea from the intra-auditory meatus, which cannot be picked up by a CT scan.